Thank you. Thank you very much for this opportunity. We are going to look a little bit more on higher order aberrations. I'm from South Africa in Cape Town, and thank you very much for being here. So I don't have any financial disclosures. There was a lot being said already about higher order aberrations in this session, so we're not going to look a lot into detail. We are going to mostly focus on spherical aberration and also on coma. And importantly, how this can help us with decision making. Firstly, how to decide or how to help us to decide when to do surgery. We are going to look more into spherical aberration and coma, and also how it can help us to not to do surgery. Okay, so this is a patient that I saw recently, 58-year-old. He complained of deterioration of his vision for the past 2 years. He was seen by another ophthalmologist and was told that his spectacles were just wrong. His vision was still unaided 20/20 for distance, but you can clearly see here on the Tracy higher order aberrations internally, he had a high amount of coma and also spherical aberrations coming from the lens. So I will offer cataract surgery for him. And this is important. So the accurate assessment of visual function interference by the lens opacities can help us to choose the best time to perform cataract surgery. We know that in early stages of cataract formation, patients may suffer from decreased visual quality, whereas visual acuity in standard conditions is still preserved. As the nuclear lens density increases, the spherical aberration in the internal optics of the eye shows a negative shift, increase in negative spherical aberration. And cortical cataract shows more amount of coma and also trefoil. So now we're going to look at spherical aberration and specifically how it helps us with intraocular lens choices. This patient was a 55-year-old female. She had previous radial keratotomies, and she was used to monovision contact lenses using the non-dominant eye, the left eye, for near vision. She was happy with the quality of vision that she had before developing cataract surgery. Note a high amount of higher order aberrations on the right eye, especially that was a dominant eye, and also a high amount of spherical aberration in this eye. So on the right eye, I've inserted aberration correcting intraocular lens of 0.2, and this helped to decrease the amount of spherical aberration on the right eye for good distance vision. On the left eye, she didn't have that much amount of spherical aberration on the cornea, so I implanted a Ray 1 EMV that actually increased the positive spherical aberration, but that gave you a good near vision. And this was now already been spoken of today about the normal corneal sphericity of that is 0.28, but to note that it is usually increased in myopic corneal ablations and usually decreased in hyperopic corneal ablations. And it is possible to counteract it with the opposite type of intraocular lens. But sorry, just to note that neutralizing this spherical aberration can give us better contrast sensitivity, and it can give us a best distance acuity, but it can also reduce the depth of focus, and by inducing spherical aberration can improve the intermediate vision, and that was also spoken of today already. It is good practice to keep it less than 0.6 micrometers, otherwise it goes into the toxic range. And this is exactly what was also being said, that the Ray 1 EMV uses mostly positive spherical aberration. Most of the other type of EDOF and also enhanced monofocal lenses uses negative spherical aberration. Some uses a combination of the two. But it is also important to note that if you have loose zonules or if you have a decentered ablation, it is safer to stay with a spherical or aberration neutral intraocular lens, especially if the decentration is more than 0.5 or 0.6 millimeters, because then you can get quite a decrease of the MTF. Now we're going to look at coma, and I'm going to explain it with this patient. This is a patient that had previous LASIK. He had complicated LASIK in his left eye with quite a high amount of irregular astigmatism, but on his subjective he also corrected to 20/20 on both eyes for distance still. He had quite a high amount of astigmatism also on subjective. So you can see here that his topography shows this irregular astigmatism, high amount of high order aberration, spherical and coma on the right eye, and even on the left eye also it looked worse, with a higher order aberrations of almost 2 micrometers, spherical of 0.6 and coma of -1.57. So now is the question, what type of toric intraocular lens to implant, and we look, try to correlate the amount of astigmatism from the different devices, also with the tracy and the subjective refraction amount of astigmatism. So implanted a toric intraocular lens, but the aberration neutral type of lens in both eyes. On the left eye, he had a refractive surprise of +2, although on the autorefraction it showed still a remaining cylinder of -1. He corrected with a +2 only and did a piggyback for him on this eye. The right eye, he had a very good result with a low amount of astigmatism that was left. And also note that at 6 weeks, he had quite a good, this was only monocular or monofocal lenses that was implanted, and he had a good functional near vision of N5 binocularly. And this is important to note that when we look at coma, the manifest refractive cylinder can be influenced by the perception of coma as astigmatism. So a cylindrical lens can provide some visual benefit and is accepted by the patient as a partial correction of the coma. So toric intraocular lens calculation, in a high amount of coma, it is important to look at the subjective refraction to guide the amount of astigmatism to treat. Also, this is shown in this graph that if you have a normal cornea, yes, then you can go straight to your K readings, but if you have a high coma, coma-like high order aberrations on the cornea, then it is needed to also look at the subjective refraction. And also to note that coma can also simulate accommodation, and specifically the vertical distribution of corneal refractive power with the greater refraction located in the lower part is most relevant to apparent accommodation. Now, just lastly, when not to do surgery. So this is a patient. He was a 59-year-old. He was a stargazer, and he had previous LASIK. So you can see here that the internal high order aberrations was actually more than the total high eye aberrations. And this we can sometimes see that the total eye coma can be counteracted by the corneal coma. And after LASIK, so he had LASIK many years ago, this increase in corneal aberrations can be negated by the lenticular increase in aberrations. And this balance between the cornea and the internal aberrations and the neuroadaptation, of course, can be disrupted then when doing lenticular surgery. So be very aware, especially in early cataracts with aberrated corneas. So then just in summary, it is very important to look at different factors. It's very important to look at the aberrations coming from the cornea and from the lens, whether you want to induce it or whether you want to use it. The pupil size have also been shown today that it is very important and remains an important factor, and all of this needs to be considered to give us a good modulation transfer function and ultimately a happy patient. Thank you.
Thank you. Would you ever consider doing a topo-guided PRK to regularize the cornea before taking up the patient for cataract?
Yes, no, of course. That patient specifically, because he was quite traumatized from his previous LASIK, and he told me he doesn't want corneal surgery at all. So he wasn't motivated, but he was counseled that it's a high possibility also after surgery. So I think overall I try to get away with as least possible. And it's amazing sometimes with the neuroadaptation how much patient can sometimes tolerate, sometimes not. But sometimes you're lucky and then you can at least just do one procedure. But definitely that's a consideration.
Thank you so much, and that brings us to the end.